Welcome to Direct Supply's Continuing Education webinar series. Direct Supply offers monthly webinars on a variety of topics throughout the year. The topic for today is challenges to seating and positioning in LTC, common seating misconceptions that get in the way. My name is Savannah Ocasio and I will be facilitating today's meeting. Please note, the information contained in this presentation is intended to provide general information but not advice about certain regulations and initiatives. This is not intended as legal or other advice, and each situation may vary depending on the particular facts and circumstances. You should not act upon this information without first consulting with qualified legal counsel. Today's webinar will be presented by Endsjo. Endsjo is an occupational therapist with a Master of Occupational Therapy degree from Nova Southeastern University and a Bachelor of Nutrition and Dietetics degree from the University of Delaware. Anna has worked as an occupational therapist for over 15 years, mainly with the geriatric population in a variety of treatment settings, including acute care, subacute care, outpatient, acute rehab, long-term care, and as a lymphedema certified therapist. Over the last 9 years, she has been dedicated to the betterment of treatment of the elderly in LTC centers. Her time was focused on seating and positioning and contracture management of the nursing home residents. Through this experience, her hope is to guide other therapists, rehab directors, nurses, and administrators through blogs, webinars, and live courses to be able to do the same. And now, please welcome Anna.
Hello, everyone, and thank you so much, Savannah, for introducing me. As she said, my name is Anna Endsjo, and I'm very excited to be here with you guys today and present to you the course Challenges to Seating and Positioning in the Long-Term Care. Common misconceptions getting in your way. With today's course, you are going to be learning 3 objectives. Number 1, name 3 common misconceptions that lead to positioning mistakes. Secondly, name 3 reasons why a K4 manual wheelchair is a better option in the long-term care setting. And then lastly, describe 3 limitations of elevating leg rest when used on a manual wheelchair. So a little bit of background information about me is I have not always been this person teaching seating and positioning to other therapists. I have a lot of skill sets. I am a lymphedema certified therapist. I worked, dabbled with hands. I did a lot of different specialty areas. But then probably about 15 years ago, I moved from one state to the other, and the only full-time job I could find was working in a long-term care setting, in a nursing home. And that is a setting that I swore to myself that I was never going to work in for all of those different, reasons. It smells. I just feel like maybe I won't be able to do as much for those individuals, so forth, right? Well, I was gladly mistaken, and I loved that setting. But when I first came on, my first day at the job, I had, went to my interview. I told them all my skill sets, all the things I could do well. And my first day on the job, they told me how excited they were that I was there because they hadn't had a full-time occupational therapist for 6 years. And their physical therapist was still a traveler and had been for the last 7 years. So they had told me on my first day that I would be the sole therapist in charge of all of the seating and positioning for all the residents in this 120-bed facility. And I panicked because just like probably a lot of you, I did not get a lot of seating and positioning at university. I went through a 3-year master's program and I got a whopping half of a day. So I felt like saying, oh my gosh, that was not one of the skill sets that I told you was really good. And I had to do a lot of learning very quickly on my own. I called a lot of my friends that were gurus in seating and positioning, and I did a lot of courses on my own, and I learned with a lot of trial and error. So I have written probably about 15 courses for the long-term care therapists, especially in the area of seating and positioning. And when I wrote this particular course, I really wanted it to be something that you could feel not, silly when I go through these misconceptions and you think, ooh, I do that, or ooh, I've done that too. It's not meant for that. It's meant for you to see that everyone makes these mistakes until someone clears them up for us. And I know that I did, and I learned through trial and error. So hopefully today you won't be feeling bad when I go through these things and you'll be like, oof, I do that, but you'll be thinking, oh, awesome. I've learned something very quickly that I can make a change and make a change for the lives of my residents as well. So as I said, I had to do a lot of learning on my own. And when I finally started feeling comfortable with seating and positioning, I finally realized that it's just really not that difficult. And I kind of thought of it as a simple equation. And I realized that if we always think about what is the appropriate cushion category that my resident should be in, and I couple that with the appropriate back support, and I always think, okay, what cushion should they be on? I need to change them out of that sling back that they're in, and then always considering what wheelchair model they have and that they're placed in, then I will always be able to end up with an optimal seating system. And when I always took into those three pieces with every single resident, no matter how easy the case seemed or how involved the case seemed, I was always one step ahead. And I was much more, I had much more success rate, because then and only then, together do those three pieces of that equation allow for us to achieve postural stability so that our residents don't slide into an abnormal posture like a posterior pelvic tilt or a kyphosis of the spine or an obliquity with a scoliosis and so forth. Then and only then, when I consider the cushion plus the back support plus the wheelchair model, can I allow for even pressure distribution. Because a lot of times when we think of making sure that we have even pressure distribution, when we talk about the bed, it's very easy, because what is the support surface that we're discussing? The mattress. The person's making contact with the entire mattress, and we want to evenly spread the pressure throughout so we don't cause a wound. However, oftentimes when we think about seating, how many support surfaces are there in seating? Two, the seat support and the back support. And a lot of times we only consider the cushion, and so we forget about wanting to redistribute pressure throughout the back, and we cannot prevent those wounds, or we cannot allow the wound to heal when they're up in their wheelchair. And then and only then, when we consider the three pieces of our simple equation, can we attain that alignment for hours on end so that our person looks just as good when we put them up at 6 o'clock in the morning than when we lay them back down in bed at 6 p.m. in the afternoon. However, I know that there's a tiny little thing called a misconception that gets in our way. And some of the misconceptions that I want to discuss today and clear up for us is the first one, that 90-90-90 is what we should be aiming for with every single resident. And unfortunately, I know that this is still being taught at our university level today. I know that because I hear new grads coming in all the time. When I have a student and I'm helping them with a patient, I'll say, okay, explain to me why you are trying to do that. Why did you make that decision? And they'll say to me, well, I'm trying to get them to 90-90-90 because that's optimal. And I'm thinking, no, it's not. And we'll talk more about why. The second misconception is that those K1, K2 standard wheelchairs that we can get for a very low upfront cost are the economical choice in the long-term care center. And yes, they have a low price tag on them, so it makes it more inviting for us because I know we're all on a very tight budget these days. However, the lack of adjustability and the lack of ability to conform to whatever that resident's body is like increases the risk of falling from the chair, increases the risk of a pressure injury, and so in the long run, it actually ends up costing you more when you have to treat a wound or you have now a hip fracture or some type of laceration due to the lack of adjustability that you get in that standard wheelchair model. The next misconception we're going to talk about is that a new cushion is all that is needed to fix a positioning issue. And I think most of us have been guilty as charged of this at one point in time. We get a referral for a seating physician, and the first thing we say when that person comes to us is, what cushion are they on, and what cushion should I replace it with? And then lastly, the last misconception will be elevating leg rest is the best option when purchasing a new chair. And unfortunately, elevating leg rests are overused quite a bit in nursing home settings, and we're going to talk about why they usually are a better option is just that standard leg rest. Okay, moving on to the first misconception. 90-90-90 is what I should be aiming for with every resident. So when I started writing this course, I started thinking, okay, why do we even think this? Why are we striving for 90 degrees here at the hips, 90 degrees here at the knees, and 90 degrees here at the ankle? And I knew it was an old school train of thought that we need to kind of break out of, but I didn't realize how old it really was. And when I did my research, I found that it goes all the way back to the 1880s and was started by a Prussian orthopedic surgeon. And unlike today, where we can't even cough without having some type of scientific evidence saying that it's the correct way of doing everything, he had no scientific proof that this was the correct posture. What he did do was base it off of that military, very erect, straight, symmetrical posture. And I guess he thought if it's good enough for a young soldier, it must be good enough for everyone. However, when it comes to positioning, especially our elderly population, we're dealing with changes in the elderly body that makes it impossible for them to even get to 90 degrees at the hips, 90 degrees at the ankles, and 90 degrees at the knees. And if that patient can get to that, sometimes they can't tolerate it for more than minutes at a time. So what are some of the changes that the elderly body has gone through that make it more difficult for them to tolerate that 90, 90, 90? And some of the things are that we have tighter muscles. So think about this. Our patients are either sitting or lying in the same posture for long periods of time. And what happens when you sit or lie in the same posture day in and day out for 12, 13, 15 hours a day in the same position? Our muscles shorten and tighten. And the muscle that shortens the most in the seated posture is our hamstring muscle. And our hamstring muscle attaches to our ischial tuberosity at our pelvis, goes down the back of our leg, crosses the knee, and attaches at the knee as well. So you have part of the muscle shortening that's pulling the pelvis forward and then pulling the knee inward. So you can't even get the pelvis to 90 degrees, and you can't even get the knee at 90 degrees. So we shouldn't be trying to force them at 90 degrees when the muscle shortening causes their pelvis to change, causes their knee joint to change, and they can't even tolerate that 90 degrees. As those muscles shorten, whether it be our abdominal muscles, our pelvic muscles, our leg muscles, we start having less flexible skeletal structures. And we oftentimes see flexion contractures or extension contractures at the hips, at the knees, and the ankles. Again, that prevents us from sitting at 90, 90, 90. So here we have a chair stuck at 90, but a body that can't get there or can't tolerate that. Another problem, as you can see in this picture very well, is that the natural progression of aging is that as we're young, we're very linear. We're very straight up. We can stand straight up. We can make ourselves into a ball. We can come back straight. But as we get older, our skeletal structural changes, and we have more of an abnormal curvature of the thoracic, cervical, and lumbar spine. We become more like a ball. So again, we have a very linear 90 degrees, yet we're dealing with a body shape that's more like a ball. And we will never be able to put a ball all the way back into the right angle of the 90 degrees because it just isn't that shape. The other thing is that our elderly population has a lot of pain. That just happens with age. I can't even get up and from, if I sit Indian style with my kids, it takes me like 10 minutes to stretch my leg out, and the whole time I'm like, ooh, that hurts. And as we get older, it just gets worse and worse and worse. And when we sit at 90 degrees, a lot of the pain goes straight through our spine, straight onto our pelvis, and so naturally those people are going to want to shift out of 90 into something that's less painful. As well, with the natural progression of aging, our skin thins. And the statistic is that after the age of 30, our skin thins with every decade of life about 6%. So imagine by the time we get into our 80s or our 90s, our skin is much thinner. We feel pain a lot quicker. We can't take a big pressure buildup. And again, if you're sitting at 90 degrees and all that pressure is going straight down your spine into your pelvis, it's going to hurt a lot faster. And then the truth of the matter is we're dealing with people with decreased mobility. So you and I, as young individuals, we can sit in a posterior pelvic tilt with a kyphotic spine, just like this lady right here that says 65, but then we can come back and stand straight up if we want. But these older adults oftentimes lose their mobility. They get tired from sitting up against gravity in the chair all day long, and they fatigue so quickly that once they've fallen into an abnormal posture because they're trying to be forced to sit at 90 degrees and their trunk muscles have to work so much and their pelvic muscles have to work so much that by the time they fatigue, they can't pull themselves back out of it, and now you have someone who has slid down in their chair, leaning over in their chair, slumping forward in their chair, that cannot get back out of that posture. So if we really want to stop those unwanted postures, prevent pressure injuries, prevent pain that lead to wounds and contractures and falls, then we need to start thinking about what angles can our elderly body tolerate. And we need to provide equipment that can be adjusted to what angles they can tolerate. Instead of trying to force a body into a 90-degree angle, we need to change the 90-degree angle to make that person be able to sit in the chair successfully. So unlike our Prussian orthopedic surgeon, we have to have evidence that states that what we are saying is true. So what I'm putting up on here for you is the fact that this 90 degrees is not what we're aiming for. So when I talk about seat to back angle, what I'm talking about, if you can see on the screen here, is where the seat support and the back support meet. That is the seat to back angle. And so you can see that if we're trying to force someone into a chair that has a straight 90 degree, oftentimes you will see this huge gap of the spine and the pelvis, and the person can never get all the way back in the chair. And so I'm here telling you that this is not what we should want to strive for. This is not what we should be aiming for. And here is the proof. There are plenty of studies out there done by Cornell University and with other working individuals that say they did these studies on young, healthy individuals that have good mobility. They don't have the pain. They don't have the shortened muscles, everything that we just talked about. Yet their bodies are not asking to be set at 90 degrees. They found that a nice, healthy, young individual is asking for an open seat to back angle. So that would be actually taking this angle here and opening it, so reclining the chair backwards, opening the seat to back angle between 105 to 110 degrees, which is optimal for them. So think about, this is a young, healthy individual with good mobility. If that's what their body's asking us for, then our elderly body definitely should be asking for about the same, not 90 degrees. So we as seating specialists are really trying to change this train of thought. And again, here, let's look at the screen. We can look at my little blue man group, as I like to call it. When we sit, and we sit straight up at 90 degrees, all of the stress goes straight down our spine into our pelvis, and our pelvis then takes on 75% of the weight of downward gravity pushing into us. And so if our body can't tolerate sitting at 90, we start sliding into what are called abnormal postures. Posterior pelvic tilt with a kyphosis, pelvic obliquity with a scoliosis, maybe an anterior pelvic tilt with a lordosis, and then again a rotation of the spine and the pelvis and probably a windswept deformity. So we ask these people to sit in something they can't tolerate. They then slide into one of these other abnormal postures where you can see they start sitting straight on some type of bony prominence. Their sacrum and their coccyx, their IT. You can see that right here. They might be sitting right on the pubic bone. They might be sitting right again on the lower IT, on the outside of their knee, right on their greater trochanter. And we start placing these patients at higher risk for pressure injuries because they're sitting directly on some type of bony prominence that should not be having 75% of the weight being placed through it. So how do we address this? How do we change chairs with a 90-degree angle and open that seat to back angle? And so there's really two ways of doing this. The first way is through the wheelchair model. So some wheelchair models actually have on the frame of the chair, it has right here where the seat to back angle meets, they have the ability to open the seat to back angle and make it permanent. So you could change it from 90 to 95 to 100, 105, whatever it might be, and you make that person's angle from there on. And that truly is the best way. Another method of being able to do this is to get a specialized back support that through the hardware, you can open the seat to back angle as well. So a lot of my patients, families or the people who I teach or my students will say to me, I work in a nursing home setting. I have a whole fleet of K1, K2 chairs that have these stuck 90-degree angles. It's unlikely that I'm going to go and be able to convince someone to buy a whole new fleet of wheelchairs. But what you can do is look at every patient as an individual And maybe what you can do is, if you can't afford a whole new wheelchair, you can afford a new back support that can open the seat to back angle as well and prevent that person from sliding into an abnormal posture because you're trying to force them at 90 degrees. If that back support can be changed, you'll be able to open that seat to back angle, and you'll be able to configure the chair to the range of motion that that person can tolerate at their hips. So again, you can either do it by the wheelchair model or by utilizing the specialized back support, or even the most optimal, both. And when we do that, we actually gain a couple of things, and I want you to look at the screen again. When we have them sitting at that straight 90-degree angle, we have all of these gaps that I was talking to you about. But as we open the seat to back angle, either through the wheelchair model or through the specialized back supports hardware, so an off-the-shelf back support, you allow maximum contact with both the seat and the back surface. So I then can now get those hips all the way back in the chair, okay? So I no longer have this gap. And when that happens, now I'm making as much contact with the gluteal and the femur so that I am spreading pressure throughout the greatest surface area. When they are sitting halfway up their chair, all of the pressure is going straight onto their gluteal surfaces and usually right onto the bony prominence they're sitting on. As we open the seat to back angle, it's now going to go all the way through the thigh and through the gluteal surface, putting more pressure through the femur, which is the biggest surface area and what we should be aiming for. Not only through the pelvis will we get more contact, we will also get more contact through the spine. So here you can see at 90 degrees, I'm really only making contact where the person's curvature is, at the apex of the curvature. So any pressure would be going straight into that person's spine right at that point. And think about some of your kyphotic patients that have reddening and breakdown right there at that apex of their kyphosis. This is why. Because you're trying to sit them at 90 degrees, they're making contact only where that bone is jutting into the back support, and that's causing them the pain and the skin breakdown. When you open the seat to back angle, you're now having them make contact with more than just that apex of the curvature. You're getting it on the lumbar spine, you're getting it on more of the thoracic spine, and you're creating a greater surface area for more even pressure distribution to prevent pain and to prevent a wound. As well, when we open the seat to back angle, the pelvis can get all the way back in the chair and can actually sit on the cushion in the pelvic well. When you're talking about a cushion, all cushions are designed with a pelvic well, which is where the pelvis is supposed to be sitting. So you can go buy the best cushion, $500, $300, $200, however expensive this cushion might be, but if the pelvis doesn't get all the way back on the pelvic well, that cushion can't do its job. And so then we think, this cushion's a hunk of junk. I just bought this expensive cushion that's supposed to do all this stuff, yet it's not the cushion's fault. It's the fact that we are trying to place them in a 90-degree chair, and the pelvis can't get all the way back, and so that cushion can't do its job because the pelvis is not sitting in the pelvic well where it's intended to, and so the cushion can't do its job. As well, as I said, since we're now not only sitting right on the pelvis, and you're not going to increase the risk of sliding into a postural abnormality, you'll take the pressure right off the bony prominences. And then again, by getting all the way back in the chair and having more contact with as much of the femur, as much of the pelvis, and as much of the spine, you'll be able to stabilize someone in that optimal posture for longer periods of time. In this picture, how will you ever be able to stabilize someone's trunk when they're just teetering off of one spot? Whereas if you can make contact with the entire spine, you can stabilize their entire trunk for many, many hours. Okay, so just as a recap, what are the consequences of using a right angle versus the right angle, the correct angle? So again, you're going to increase this person's risk from falling from a chair because less contact is being made with the seat and the back surface. You're not going to be able to stabilize the pelvis, the trunk, or the extremities because you're only going to be making contact with a small amount of the body. You're going to be increasing the risk of a wound development because we're not considering what range of motion this person has. If they can't even get to 90, don't try to put them at 90. If you start seeing that their pelvis, when you have them on a flat mat table and you're going into hip flexion and their body starts moving as a whole unit at about 110 degrees, that's where the seat to back angle should start in your chair, okay? It's impossible to match chair angles to a resident's joints at 90 degrees. You have to consider what they are able to achieve. And so then the residents start to slide into those abnormal postures, and you will get peak pressures right at those bony prominences. As well, if we're sitting here talking about the importance of opening seat to back angles, I have to mention to you that it's just as detrimental to open a seat to back angle too much as it is not to open it enough. And so here is my little dig on tall recline back chairs. You know, if you were to be able to seat them at 105 degrees where they want it, and that was perfect, and no one was going to open it more or less, maybe, okay? But tall recline back chairs have a lot wrong with them. The first thing is you're using a chair that can go back very, very far, and oftentimes what happens is the family comes in and they say, oh, Grandma, she looks so uncomfortable, let me just recline this even more. Because we kind of think of a lazy boy, and you think about reclining someone. Well, the further and further and further and further you recline, what happens to that person's body? It becomes like a slip and slide, and they slide right on out of the chair. So opening the seat to back angle too much can be just as detrimental, especially when we start using those tall recline back chairs. We promote sliding and slouching and leaning in the chair because if it's too close, like they bring it up and the person gets left that way, they are trying to sit straight up against gravity, and it's not even a smaller back height. You're talking about a very tall back, so it's really pushing that person up from the head all the way down to the pelvis, and it's going to fatigue their body even more. And then if you open it too much, you're going to cause them to slide right on out. So again, either way, you're going to start putting peak pressures right at those bony prominences. So what should we aim for? Again, get that person out of the chair, look at the resident's body to then determine what angle at their hips can they tolerate. And if you see that their body starts to work as a unit and you have them on the mat, and when you bring them into flexion, their whole pelvis starts to raise, stop there. And that's where you start with the seat to back angle. So that might be 100, 105, 110. So look at what the person's body is doing and match that seat to back angle to their range of motion. The next thing is open or close. There are times you actually do close, but most of the time you have to open the seat to back angle so that you can get the pelvis all the way back like we've already talked about. And then the last thing that you should be aiming for is changing that sling back off of the chair. Avoid tall recline backs that cannot have the back support surface sling back changed. And not only open seat to back angle, but change that sling back for a back support that can be conformed to the person's spine. So this is kind of like not good, better, and best scenario. Not good, obviously, is sitting them at 90 degrees, which we've talked about. Good is we've opened seat to back angle. We can get the pelvis back. We have the most contact with the trunk and the pelvis. And the best scenario is get that seat to back angle, get the hips back, and then wrap around the contour, whatever their contour of their spinal curvature is, whether it's normal or abnormal. You can use a back support that can wrap around them and make contact with the entire spine. So instead of just having pressure enter like daggers in a small surface area, you have pressure entering the entire spine to really stabilize the entire spine and prevent pain and pressure injuries from developing at any apex of a curvature. Okay, the second misconception is that those K1, K2 chairs are what we should be striving for. And I love this picture because I love new car shopping. And, you know, that car salesman will actually spend a whole 5 to 15 minutes with you on why you should upgrade to the highest model because you need a chair that can conform to your body perfectly so you will be completely pain-free in your 30-minute, 40-minute, 1-hour commute, okay? And they'll brag about how the back can contour to your spine. You can bring up the front of the chair and create kind of like a fixed dump. You can get a little bit more lumbar support. The armrest can be raised or lowered to meet you so that you're not, you know, bringing your shoulder up, and you'll have nice, calm muscles in your shoulder and neck and head. The head support can support you right where you need it. And there's even a little button for you to push so it's perfectly set to your body every single time you get into the car. And they want you, and they convince us that we should be comfortable in that 1 hour, maybe 30-minute, whatever amount of time commute that we have to work every day. And you know what? They have a point. They're right. We only have one body, and we should take care of it. But we are so willing to buy a car that has all this luxury and all this adjustability to conform to our body so that we can be comfortable and pain-free for our 30, 40, 1 hour commute, then why aren't we trying to do the same thing for our residents that are sitting in a chair, not for 30 minutes to an hour, for 4 to 6 to 8 to 12 hours a day in their wheelchair systems? Okay, so in the nursing home, there are some states out there that have a lot of luck, and they have Medicaid funding, and you guys can get these power chairs and K5s and all this. But in most of the states, we have to rely on our nursing homes to really provide us with the wheelchair models that we need for our patients. So those of you that are in the pockets of the states like with Washington State and Ohio that really have that Medicaid funding, please count your lucky stars. Those of us that are not in those states and we really have to fight for everything we purchase to justify it through our facilities or with the families, you will probably understand this part a little bit better. And, you know, when we have to choose the models ourselves, I bet a lot of us don't even really know the differences between a K1 and a K4 model. And so a K1 is that typical, non-adjustable, at-all wheelchair that you probably have a ton of in your storage closet. A K2 is more of a hemi-height chair, can get lower to the ground, but again, nothing else can be adjusted. And a K3 is the same thing, that it's, you know, a 90-degree chair. It can get even closer to the ground. It's a little bit lighter. And then a K4 is a high-strength, lightweight chair. So it's got the lightweight, but it has a lot more adjustability. And I do want to say one thing right there. There are some K4 chairs out there that do not have any adjustability. If you buy a K4 chair, you call for a quote, you must say, I want a K4 chair with armrest height adjustability, seat to back angle adjustability, because if you don't tell them that that's what you want, you'll just get a K4 that has the same no adjustability as the rest, and there's no point in buying that chair. You want a K4 chair with adjustability, and this is why. So this is straight out of dealers' mouths. These are the people that sell wheelchairs all the time, and this is what they are telling you, that a K1, K2, K3 wheelchair, which is what we have in most of our nursing home chains, what they're good for. They are a wheelchair that has the bare necessities with no outstanding features. There is no frame adjustment or modifications. And then you might be getting a little bit warmer if we start using a K3 chair, because usually it's made with a lighter material that makes it about 5 or 6 pounds lighter. So someone who propels themselves will be at less risk for a repetitive strain injury and less risk of putting more pressure on the heart or their pulmonary systems. And it also has the ability to get 2 inches closer to the ground. So most manufacturers, when we talk about a K1, it's 21 inches off the ground without a cushion. So then you add a 2 to 3 inch cushion. You're talking about a very tall person that needs to sit in that chair to be able to hit the ground to get a good heel strike for self-propulsion without bringing their pelvis forward in order to reach the ground. Not many of our patients are that tall. A K2 chair usually can get somewhere from 19 to 17 inches off the ground. Again, you're talking about a very tall person once you put a 2, 3, 4 inch cushion in there to reach the floor to get a good heel strike without compromising the position of their pelvis. A K3 is usually about 17 inches off the ground. And so what I'm trying to tell you guys here is that even though a K1, K2, and K3 has a little bit of difference in seat to floor height, the skeleton of those chairs is exactly the same. You have a stuck 90-degree angle, and we just talked extensively about why we shouldn't be sitting at people at 90 degrees. So here we are again in those 3 models trying to force the patient that can't get at 90 or can't tolerate it to sit there. Frame is exactly the same. All right, so now we're going to perform a little exercise. What I want you to do is I want you to visualize walking up and down your nursing home hall. If you're a home health therapist, think about walking in each of the houses that you've got to go to. And what I'm going to do is I'm going to read off the criteria that dealers say that K1, K2, K3 chairs are good for. these people have this criteria, these are the type of people you should be positioning with them. And hopefully what I want you to see is that as I read off this criteria, you're going to be crossing all of these individuals off your list. So the first thing is that is appropriate for a K1, K2, K3 wheelchair is this is someone who sits with good postural control. So that doesn't mean they fatigue at all after sitting a couple hours in their chair. This is someone who has minimal to no postural deformity. So they don't have a kyphosis, they don't have a slight posterior pelvic tilt, they don't have anything wrong with their skeleton. They can sit nice and upright for most of the day. These chairs are good for people who sit in a standard size wheelchair without any compromise. So most of these chairs come standard in 16 by 16 or 18 by 16. So that is not the length or the width of a lot of people. I do not fit in a 16 by 16. I am 5'8" and I weigh 145 pounds, and I don't fit in a 16 by 16. I need at least an 18-inch depth. This is good for someone who has no discomfort or pain with prolonged sitting. I can't even sit in a chair without pain for prolonged periods of time. This is a chair that is good for short periods of time, for like 2 hours at a time, for short distances. This is good for an individual that can functionally propel the heavy weight of these chairs to perform all their ADLs without any type of pulmonary or cardiac compromise, or even pain in their shoulders or their feet from propelling all day long. And again, the K3, you are getting a little closer because Medicare says that this is better for someone who has a physical condition such as a cardiac issue or pulmonary issue because it's a lighter frame. However, I'm hoping that you just saw with that exercise that that chair should probably not be used with any of our residents in long-term care. Does it have a place in our nursing home settings? Sure. It has a place with those short-term patients, those patients who have come in after a car accident or they just had a stroke or hip replacement or knee replacement, and you know that you're going to get them back to baseline. They just haven't gotten there yet. They still walk some, but they need the chair for when they fatigue a couple hours a day. And then they walk a little bit more, and then they need the chair maybe a little bit more throughout the day. So they're not sitting in this chair for more than 2 to 3 hours at a time. They are not meant for someone who is in the chair as their primary mode of locomotion all or most of the day. Why does someone who is in their chair for all or most of the day need more than at least the minimum of a K4 chair? This is why. The minimum of a K4 wheelchair should be used with anybody who needs to sit all or most of the day in their wheelchair. That should be most of the people in your nursing home. Someone presenting with limited mobility or is non-ambulatory at all needs a minimum of a K4 chair. Someone with good postural control needs a minimum of a K4 chair. They present with postural deformities. They have a stuck kyphosis or a stuck posterior pelvic tilt, something that they cannot get out of. Someone who needs a non-standard size, maybe a 19 long and a 15 wide, whatever it may be, to sit in the chair to prevent slouching or sliding or leaning because they need something that's fit exactly to their dimensions. This is meant for someone who has discomfort or pain with prolonged sitting, more like our residents. And this is meant for someone who cannot functionally propel the weight of a chair against carpets, against thresholds, around the room for long periods of time in order to perform their ADLs. So what is the adjustability that can come with a K4 model? And again, I'm going to remind you of this. Not every K4 has adjustability. When you call to get a quote for a K4 model, do not get a K4 with no adjustability. You might as well just get the K3, the K2. You need to get a K4 model that has seat to back angle adjustability, armrest height adjustability, and seat to floor height adjustability. And a good K4 can get as close to 14 inches off the ground. Now, why do I say this is good for most nursing home settings? Because we usually have to pay for our own chairs. And a K5 wheelchair is way out of our price range. And K5 wheelchairs are coming customized to that specific person. If you, again, are in a pocket of the country that you can get a K5 wheelchair for every patient, fantastic, do it. But a minimum of an adjustable K4 should be used in most of our nursing home settings. So what is the adjustability that comes with it? seat to floor height adjustability, which is getting close enough to the ground so they can get a good heel strike without sliding forward to reach the ground. As well, armrest height adjustability. And we don't think about this enough. Think about those standard chairs that the armrests are all the way up here. Well, look what I just had to do in order to touch the armrest. I had to elevate my shoulders, and so after a while, I'm going to get tired. My muscles are going to start contracting. I'm going to fatigue, and that person's even at risk for some type of shoulder impingement and pain. And that's all from using an armrest height that is too tall. As I get tired, I'm going to start sliding down in my chair, and the armrest heights are going to get higher and higher, okay? If the armrests are too low, I have to depress my shoulders to try to reach them. Well, I'm not going to be able to reach them, so what do? I'm either going to lean over to reach just one of them, and now I've just promoted an obliquity with a lateral lean, or I'm going to slide into a posterior pelvic tilt in order to be able to touch the too low armrest. So a lot of times we don't think that armrest height can actually be promoting the abnormal posture that we're seeing. The other thing is, and I talked extensively about this, is the seat to back angle. That is critical. Back height, if you're not taking off the sling back, you can take that back up and down. And also you can create what is called a fixed tilt or dump in the chair to take some pressure directly off the pelvis. And you usually can do that with playing with the front casters. And this is something that is just given to you in your slide. And this is, again, differs from manufacturer to manufacturer, but this is a really good guide that we have created for you so that you can remember what each of these models do and why you probably should be staying away from the first three with someone who is a long-term sitter, and you should be going with at least the minimum of K4. So just remember, with this misconception, hit a home run. You really want to look for a chair that can be molded and changed and readjusted to fit various types of body instead of trying to take various body types and mold it to one shell. We all do not have the same shape, and we should all not be trying to be forced to sit the exact same way. Okay. The third misconception is that a new cushion is all that is needed to fix the positioning issue. And so, we get that referral, comes across our desk because we have a resident that has pain in sitting, or they've developed a pressure injury, or they've had a fall from the wheelchair, and our mind immediately goes to, it must be the cushion's fault, right? Wrong. So what we have to consider and we have to keep in mind is that the pelvis does not work alone. We are all therapists. You will never be able to stabilize the pelvis well without considering the trunk. And the trunk will never be able to be stabilized without considering the pelvis. So the overall alignment isn't impacted just from fixing the pelvis. It's changed by considering the trunk, the head, the extremities, the lower extremities, even all the way down to the foot and the ankle, okay? The second thing is that best cushion on the market will lose all of its effectiveness if not used in the combination with the correct model wheelchair, that you have the adjustability to configure to that person's body angle, and without using the appropriate back support, that you can conform to that person's spine to create the most upright posture, to create the most stability so that they can sit in that optimal, whatever their optimal is, for long periods of time without the risk of falling out of the chair and without the risk of developing a pressure injury. And then lastly, that a back support is just as critical as the cushion in an ideal seating system. And my personal thought is that no cushion should go out the door without a back support. Again, we can't completely stabilize the pelvis without the trunk, and we can't do the trunk without the pelvis. And sometimes we just don't know what came first, the chicken or the egg, right? What's throwing off the pelvis? Is it the trunk, or is the trunk being thrown off by the pelvis? A lot of times it's just a combination. So what does a back support do? What is the role of a back support? Why should we take off that hammocking, too tall recline back? Why should we replace that with an off-the-shelf back support? So the reason why is, just like a cushion, that we want to immerse that person, to sink them in, and then wrap around their contour to protect them and to stabilize them, we should want the same for our trunk. And the other thing that we need to do through a back support is that we can now capture their curvature. They could have the most abnormal posture, the most kyphosis, a horrible scoliosis, a very significant lumbar lordosis, a rotation of their spine, and we can capture that with an off-the-shelf back support that has posterior contour ability, okay? And you can see that very well right here. If I use that straight back, like the straight tall reclined back or a sling back, I'm only going to make contact with certain points on the spine. I will never be able to stabilize that person and get them aligned for hours on end. When I use a back support that can be contoured and can capture their curvature, no matter what it is, I am then able to stabilize the entire spine and have even pressure distribution throughout the entire spine. When I use just a straight back, again, you're going to have pressure entering only at the apex of the curvature in a small little diameter. It's going to be like, as I like to say, some of my coworkers laugh at me, but like daggers of destruction going straight in one small area. Whereas if we are able to contour, immerse that person, envelop their curvature, no matter what it is, I'm having pressure enter along the entire spine, and I'm no longer going to have one point of entry that's going to cause me pain and put me at risk for pressure injury. The pressure is entering through my entire spine. I'm not teetering off of only one point, trying to stabilize someone off of one point. I'm stabilizing the entire surface area, and I'm going to have much more success. As well, when I use a specialized off-the-shelf back support, I can usually add, if it's a hard shell, I can then add mounted laterals. I can then add a head support. I can't do that on a sling back. And again, we can replace those overstretched, hammocking sling backs that's lost its shape and do not stabilize our patients at all anymore. So I'm going to drive this point home with this slide for you. This is a patient that I was called in on to do a case study. And this is a picture of a friend of mine who said, Anna, I just don't know what to do. I have this person, got her in a tall recline back chair. You know, it's not the width that I know that she needs, and you can see that. She tried to put in a lateral, and she did okay with the cushion. The cushion was not a bad cushion. However, here she's got elevating leg rest, a tall recline back that can be conformed to her. She's got a chair that's too wide, but the cushion was not the problem. In this picture, the after picture, I never changed her cushion out. But this is the perfect example that I could have the best cushion on the market, and if it's not used with the right wheelchair model and the right back support, it can't do its job. So she was sitting on top of the contours. Those contours weren't even doing the right thing because her hips weren't all the way back in the chair. So she was sitting halfway up the cushion on top of the contours that were supposed to be aligning her lower body. So what we did is we came in, we changed out her wheelchair model, we opened her seat to back angle, we gave her a back support that we could then wrap around her curvature to stabilize the entire trunk and to redistribute the pressure over the entire trunk because she had a lot of pain. She could only tolerate sitting up about an hour and a half. We got an armrest height that could be adjusted because here you see the armrest is too high, so it's pushing her over to the side. And you can see that it doesn't have any ability to be elevated, and so you can see all of the edema in her hand. And also by utilizing the better back support, we were able to use a mounted lateral to keep her as close to midline as possible and also to add a head support to give her head the support it needed to stay upright, to then converse with the people around her, have a good eye gaze, be able to get out of the chair and talk to her husband, to be able to have a good swallow, and her quality of life changed drastically. So I never changed the cushion. I just allowed her to sit on that cushion correctly by changing everything else. All right, and the last misconception is that elevating leg rests are the best thing since sliced bread, right? And that they're the better option when purchasing a chair. So some of the reasons that because there are times when an elevating leg rest should be used. So again, I don't want you to think that you should never do any of these things, but we should know why we're doing it and why we shouldn't be doing it. So a lot of times I'll hear reasons like when I have students or I see the nursing staff that's asking me to put them with elevating leg rest, and I'll say, well, why do you want elevating leg rest? And they'll say, well, because, they'll keep the hips back in the chair, or they help reduce edema, or they decrease the pressure on the pelvis, and they assist with lower extremity alignment. So they must be a better option. Absolutely not, okay? And the second thing is that elevating leg rests are about $200 and some more expensive than standard leg rests, and they don't do much better for the patient, and we're going to learn why. So the first thing I hear a lot of times is that they keep the hips back in the chair. So if you remember back to one of the first slides where I showed you why a patient shouldn't even be trying to sit at 90, 90, 90 because they can't tolerate it for all the tightened muscles and so forth, we talked about the fact that one of the tightened muscles is our hamstring. It runs straight from our ITs down the back of our leg, crosses the knee, and attaches to our knee. So as that hamstring muscle shortens, it pulls the pelvis forward and it brings the knee backwards. And as it pulls the pelvis forward, it's attached here at the ITs, and it's pulling that person into a posterior pelvic tilt. And as you're pulling at those ITs, what are you doing to the pelvis? Are you keeping the pelvis back, or are you bringing it forward and out of the chair? Bringing it forward out of the chair. So as we elevate the legs, we pull on those already tightened hamstring muscles. So the higher and the higher and higher we go, the more and more and more we pull on our IT, and we start to pull the person straight out of the chair, which is right on more of a sacral sitting. So now they're going to be sitting straight on their sacrum and their coccyx, and the resident slides out of the chair, the exact opposite of keeping them back in the chair. So a lot of times, the higher we elevate that leg rest, the more risk we have of our patient sliding out of their chair. The second reason I hear a lot of times is that they elevate, they reduce edema. And I would get this a lot from our nursing staff. They'd say, Mrs. Smith's legs are very swollen. I need you to help me get some elevating leg rest. And we all went to school. We all know, how do you reduce edema? You have to get that extremity above heart level, okay? And in the manual wheelchairs that we use in our nursing homes, those K1, even up to K4, K5, you're never going to get that leg 30 centimeters above heart by using an elevating leg rest on the type of manual chairs that we have, okay? So RESNA is the governing body of all seating and positioning for therapists. They put out all of the research and make all of the, make the ATP certificate and the SMS, and they do a lot of research, and they have things called positioning papers. And one of their papers talks exactly about this. And it says that in a manual chair, or in a chair, period, you must elevate the legs 30 centimeters above heart level in order to reduce edema. And that is usually seen in a power chair with a tilt and recline function, not in the manual wheelchairs like this one. You'll never get this leg 30 centimeters above heart. And then if you really think about what's going on, you can see that the higher the legs go, the more that we are creating a flexion here at the hip joint, and we are actually cutting circulation off at the groin, cutting off the blood supply to the leg and the return to the heart by closing that angle as we elevate that elevating leg rest. So here are some things that we can do as an IDT, an interdisciplinary team. And some of the things that you as therapists can do is really look about making a schedule. If it's someone who can walk, making sure they're getting on a restorative program, that they get some of those exercises or walk through the day, whether it be active range of motion or passive range of motions, to get that blood pumping again. And the other thing is, as I said, I am a lymphedema certified therapist. And if you are going to get some type of compression stocking for your patients in the chair, please do not mistake a TED hose for compression stocking. TED hose has about 10 millimeters of mercury, and the TED hose has the same compression from the toes all the way up to the knee. It is not going to mimic the compression that a true compression stocking has. That a true compression stocking has 100% compression at the toes, and as it goes up the leg, it gets less compression. So it might be 100, 98, 95, and as it goes up the leg, there's less compression so that it can mimic the pumping of the blood and the fluid from the lower extremity back to the heart. So please, do not put a TED hose on your patient and think that this is a compression stocking. You will truly need to fit them for a true compression stocking if you want to use that in combination with a dependent position like a wheelchair. Other things is that as the nursing staff and the medical staff look at their medication list, look at things that really increase the retention of water, the diets, ask the dietitian to look at it, things that we can change as a medical team to maybe reduce edema in other ways. Okay, the next thing is that we think that it reduces the pressure on the pelvis. So elevating leg rests actually do the exact opposite. So once again, we talk about how we have these patients, as we elevate the leg rest, we start to pull on those already shortened muscles. that are going to pull the pelvis into a posterior pelvic tilt, which is sacral sitting. We're going to force them to start sitting right on their sacrum, their ITs, and their coccyx. And we're placing them at higher risk because you're pulling the pelvis out, and now they're sitting directly on those bony prominences that are digging into the cushion, and 75% of the weight is going onto that pelvis, right? So the higher and higher and higher I go, just think of gravity. I'm no longer making contact with the femur. The femur doesn't even make contact with the cushion at all. And gravity is just forcing all of the pressure downward and back onto that pelvis that's sitting directly on the sacrum, the coccyx, and the ITs. So by utilizing elevating leg rest, you're actually increasing their risk for a pressure injury as well. And then the last thing is that elevating leg rest help with lower extremity alignment. And again, as we raise those elevating leg rests, we have less femoral contact with the seat support. So here you can see that the femur isn't even touching the cushion. All that's touching the cushion is our gluteal surface. So as our legs stay up here, we get tired because they're trying to just in limbo. And so what happens is as we get fatigued, our legs start falling off the leg rest. Our knees will start coming together, as the woman here, into adduction, or they might go falling off on the sides into extra abduction. And either way, they might fall in between the leg rest or they might fall over the leg rest, and you're placing them at higher risk for A, the legs and the hips getting contractures because they're now sitting in that type of position for long, long periods of time, skin tears, a foot getting caught under a leg rest, some type of ankle injury because you ride over it. So many things can happen because we don't have the lower extremity aligned well. And windswept deformity definitely becomes more prevalent. So just look at the difference. Here's the same patient again with elevating leg rest. And here I have her on standard leg rest where her pelvis is back. Her legs can sit in the leg troughs of the cushion where she's making good femoral contact. You can see that. And her legs are in great alignment. So let's just put all the pieces of the puzzle together and think about that equation that I talked about. If we always consider utilizing the correct back support, always consider utilizing the correct cushion, think about the type of leg rest and that more times than not, standard leg rest will do the job, and couple that with utilizing the appropriate model of wheelchair, then we will be able to get a complete optimal seating system so that my hope for you is that you will see a whole lot less of the picture on the left of the screen and a whole lot more of our resident on the right. So that wraps up the course. I hope you guys enjoyed this, and we're going to open it up to the questions portion now.
We now have time for a few questions that did come in. Why do wheelchairs with slingbacks if oftentimes you have to replace them? Why do they come with slingbacks if we often have to replace them?
Okay, great question. I've actually been asked that question before. And so the reason is, and I always make this analogy, you can go buy a phenomenal pair of sneakers, a great pair of Sauconys from this high-end running shoe store, or you can go to Shoe Bar and buy, a $40 pair of Sauconys, or you can go buy a $180 pair of Sauconys from the running store. But, sorry, my earpiece just came out. What the difference in the price of the shoe is, what kind of cushioning material it has, how big or wide the toe box is, what is the arch support like. But what they didn't put money into was the flimsy, thin foam insert that goes in both of those shoes. If you have some type of issue like plantar fasciitis or chronic Achilles tendon problems, something like that, you usually have to buy yourself some type of insert to go in that shoe to accommodate for that problem that you may have. So that's the same kind of deal that comes with these wheelchairs. A manufacturer has to send it out with a back on it, but they're not really putting all the money into the back at all. If your patient has some kind of postural abnormality or contracture, like a kyphosis or a lordosis or a scoliosis, then they're expecting you, just like that orthotic, to buy something that can be shaped and conform to that specific person's issue. Because to all of us are so different, they can't give us a back support that can meet all of those needs. It is up to us as therapists to then go and find the back support that can be meeting the needs of all those people.
Awesome. I think we might have touched on this, but do all K4 model wheelchairs come with that kind of adjustability?
No, all K4 models do not come with that adjustability. You must ask for it. And some K4s might only come with seat to back angle adjustability. And another K4 might only come with seat to floor height adjustability. So you have to ask for, does this K4 model have seat to back angle adjustability? Does this K4 model have armrest height adjustability? How low can this K4 model get? Can it get 14 inches off the ground, 15, so forth? So we really have to make sure that we're asking for a quote for an adjustable K4.
All right. Do we want the patients at 90 degrees for optimal positioning during self-feeding for a safe swallow?
Okay, so again, that really depends on the patient. If that patient cannot get to 90 degrees, you're never going to have them positioned that way because their body just can't tolerate it. And most likely what you're going to do is you're going to be trying to get them at 90 degrees, and they're going to be sliding out. It's much better to get them to the angle they can tolerate, get them sitting up as tall as they can by using a back support that conforms to them and getting a head support than try to shove them up to 90, and then they can't tolerate it, and then they're going to be sliding down. So, no.
We have one more question. Do the off-the-shelf cushions have a rating for durability? I was wondering if there was some sort of method to suggest to my facility when to replace a cushion.
Right. That's a great question that I get asked all the time. And no. So every manufacturer, really, it's different from manufacturer's cushion to manufacturer's cushion. The only thing I can really answer, the way I can answer this to you is, in order to make, because now I work for a manufacturer, and in order to make a good quality cushion that can last 6 months to 7 months to a year, you have to get good quality products. So just think about this, guys. If you're buying a $40 foam cushion, then think that $40 foam cushion is not going to last a very long time. Because foam, for example, is the way that it is priced is from the density. And the density is how long it can take compression with a big load, and that type of foam is quite expensive. So if you're getting this great deal of $30 or $40 for a cushion, there is a reason, and most likely that durability is not going to hold up. If you start getting into higher-end cushions from manufacturers that devote, studies on foam and studies on their air and studies on their gel and so forth, and you're starting to pay in the upwards, because that's usually a good sign of good quality of a product, then that cushion should be lasting you anywhere from 6 months to a year. So like Medicaid guidelines allow you to replace a cushion every 2 years. So if you are using a good quality product from a good manufacturer, you should be getting a good 1 year at least in that product. If anything is going less and you're starting to see it getting flattened, that is not a quality product. That you're maybe cheap, but you're going to have to start buying a whole lot more of them more often. So.
All right, thank you. That is all the times we have for questions today. And now for anyone interested in learning about seating and positioning products that Direct Supply offers, please help me welcome our fantastic product manager, Kelly Sullivan.
Hi, everyone. Thank you for spending the next couple minutes with me. I'm going to talk through a handful of products here that will relate back to the presentation that Anna just delivered to you, in that we have a few products that do allow for some adjustability, and I want to make sure that you were aware of a few of these pieces so that if you have a need in the future, you know where to find them. The first product we're going to talk about is a wheelchair with that K4 rating. It has a lot of adjustability available to you. Some of it is going to be customized, though, so you'd have to contact your account manager in order for it to be given some of the adjustability features that we're going to cover today. What it does come standard with is it's going to allow for adjustable height armrests. So just by moving this piece here, you can adjust the armrest to be suitable for the individual's body and their type, and to help support the torso. And also, we have the ability to adjust the seat-to-floor height from 17.5 to 19.5 seat-to-floor, just right here with that dual axle. You also have the ability to adjust the back in 1-inch increments, the height of the back. So that comes standard with the chair as well. And then you have the ability to choose your front rigging. So your swing-away footrest, your elevating leg rest, or you're articulating a leg rest, depending on the needs. The 9000 XT from Invacare is the one that we're talking to. The 9000 SL also has the ability for you to order the back at a degree, reclining by degree. So you will have to order that as a customized chair, though. It has to be configured in our system. I just wanted to point out, though, that is the bracket. Hopefully we can zoom in there, where we can toggle between different degrees from 85 degrees to 110 degrees. Where we have it set right now is at 110 degree recline. And that's something that you will need tools for. It is not a toolless adjustability. But it does give you lots of options. If by chance you needed a 13.5 seat to floor height, you can do that with this chair as well. Again, it is a customized option, so you'll have to contact your seller in order for that to be configured into a quote for you. But there are a vast amount of options here. Whether you want to have a 22-inch wide seat surface with an 18-inch depth, we can configure that as well. We have varying different levels of weight capacity on this chair as well, ranging from 250 pounds outward to 300 pounds, or 350 pounds, excuse me, on the 22-inch chair. So lots of options, and I just want to be sure that when you walk away today, that you do know that there are options through Direct Supply for adjustable back and adjustability in general to accommodate your residents' needs. Next, we're going to talk to a product called the Elements Back from Comfort Company. This product is used for general use most of the time. It's a great back in that, as you can see on the screen there are straps. It's a strapping system that will accommodate hip ounces or provide lumbar support, for instance. It also gives you a 1-inch foam that's going to be much more comfortable for the resident. It replaces the current sling back quite easily just by securing to the wheelchair cane. And it has adjustability in sizes, so you have a range of 15-inch to 21-inch wheelchair, and then there's another option for a 22 to 25-inch wide wheelchair. Lastly, you'll see, too, that it can fold. And that's a really nice feature in that if I'm using the chair in a transport method and I'm taking it with me somewhere, I don't have to remove the back. I don't have to, try to work that back onto the wheelchair when I get to my destination. It can just easily fold and be stowed away until I get to where I'm going. All right. The next product I'm going to show is called the Incrediback. So this product has 6 different models. It has a 450-pound weight capacity. The models range from rigid to moldable to tall to steep, meaning there's laterals to support your resident. It has adjustable, let me pull this out so you can see, moldable aluminum stays. It's a patented product here, in that you can bend that aluminum stay to really conform to the resident and ensure that we have a customized fit for them. The back, again, as I mentioned, is moldable, so you can push back into that chair and really conform to it. And it does replace your sling back. Pretty easily, though, as you can see, it's a strapping system, so there's no tools necessary for it. So really nice option here. It does have the ability to recline to about 30 degrees, and that's for all 6 of those models that were mentioned. So that's a great product, and if you're looking for, okay, I've got a K1 or a K3 chair, for instance, how can I configure this chair on my own without having to invest in a K4 chair? So these are some of those products that you can now replace the backs of the current sling that you have and give them a little bit of adjustability and allow for them to conform into that seat. So Incrediback is a great option to consider. And then I have, lastly, a cushion. We talked about cushions and contours, or I should say Anna did, and there are some really nice options out there that are affordable. You don't have to spend $1 million to customize and build out that seating system. You can invest in a cushion such as this one here, which is the Comfort Company Glide, which uses a specialized cover that we'll talk to you in just a second here. But really, you don't have to spend hundreds of dollars on a cushion that's going to allow for good positioning and immersion, and also comes with some specialty features that we'll talk to you now. So you can see on the cover here, maybe I should hold it up, there's a different type of fabric right here in the pelvic region. This is called glide wear. This is built into that pelvic region for a reason. Think about micro movements. If you're adjusting and shifting or you're reaching for something, you're going to shift and move. And your fabric on your clothing is going to shear and move with your skin. And as we all know, skin becomes more fragile as we get older. So there's going to be more skin integrity issues in that pelvic region as we are shifting and moving. So this is a nice piece that's built into the cover here that allows for you to have some adjustments and movement, yet still giving you high coefficient of friction right here in the front of the cushion, so you're not going out like a slip and slide out of your chair. So it's a great little addition to this cover. Now, if we look at the contouring, you can see there's a nice medial thigh separator here to help with alignment and posture alignment, help position you back into that seat. It also has, if I open it up, you might be able to see, let's see if we can show this, but this has an anti-thrust pelvic contour as well. Maybe I can off to the side here. There's a bit of a carve out here in the pelvic region, and then it gives you a little bit more foam up in the front to help give them a gentle reminder of if there is some slide or posterior pelvic tilt. So great cushion, comes as a nice quick strap, so you can secure it to the wheelchair. If you're transferring someone in and out, it doesn't slide out with them. The bottom also has a non-skid bottom to the cover itself. So great little option here, and again, cost effective. So if you're looking for a solution that you can add to your current seating system that is affordable, that's manageable, that allows for you to do it in the field, we had a couple options you could consider. Otherwise, no, we do have those K4 chairs, that Invacare 9000 XT and also the 9000 SL to choose from. Just remember that some of those features are customizable, so when you're talking to your account manager, they can customize it for you over the phone. If you have additional questions, feel free to email, and I'd be happy to answer them or link you to Anna if they're more clinically driven. But thank you again for sticking around, and I'll see you next time.
Thank you so much, Kelly, for that informative presentation. If you have any questions, like Kelly said, about the products discussed, please reach out to your Direct Supply account manager or webinars@directsupply.com. For more information about upcoming webinars, please visit directsupply.com/webinars. Once again, thank you for attending today.